Hello, and welcome to Healthy Living. I'm Dr. Donald Pelto, and today I have here with me Dr. Rock. He is from the Holden Urgent Care. So, yes. Rock, please tell me a little bit about yourself and welcome to the show.
Thank you very much. Thank you for inviting me. My name is Rock, Jean-Guillaume. My patients like to call me Dr. Rock so they don't destroy my last name. And everyone knows me as Dr. Rock. I am currently part owner of the urgent care of Holden, but we have my business partner and I, we own two urgent care, one here and one in Wilbraham. The Holden urgent care was the second urgent care that we started. The one in Wilbraham will be 6 years old since we opened.
Wow.
Yeah.
I've been seeing a lot of these urgent cares open up, and I'm sure a lot of people in the community. Yeah. Who opens urgent care? Is it emergency room doctor, primary care doctor?
That's a great question. The urgent care industry has bloomed ever since the Accountable Care Act was made rule. And thanks to Obamacare, Accountable Care Organization, more Americans are now insured. So that has helped the urgent care business flourish.
Yeah.
So who opens an urgent care? Anyone can open an urgent care. In fact, there are many national urgent care organizations that are sporadic and are scattered throughout the country. Our urgent cares were opened by two emergency physicians.
Okay.
And many of them are staffed by emergency trained folks. Our urgent cares are definitely staffed by emergency trained folks, and we have a little statement that's a blurb that we use with our organizations that says we're bringing life's little emergencies to the urgent care, basically. There are many types of providers that work in urgent care. Sometimes they're not emergency trained.
Yeah.
We happen to think that it's beneficial for us because we can discern real emergencies and those that are urgent that we should manage and disposition people accordingly. So in terms of anyone can open them, any licensed provider can open them.
Yeah.
But they're oftentimes run by hospitals or national agencies.
Okay. Now, when you talk about national agencies and hospitals, we had this conversation before, mid-level, so are there physician's assistants, nurse practitioners, are they going to be seeing you? Will a doctor be seeing you? Is someone supervising?
Yeah, we have both at our place. We have 4 physicians and 2 advanced practitioners, which happen to be physician assistants. And our physician assistants trained in the emergency departments with us. So they came over with us. So they're very talented, very intelligent. They can, again, discern serious or potentially bad outcomes and dispositions of people appropriately. But urgent care settings, you will find advanced practitioners as well as medical professionals, medical physicians, I should say.
Yeah, and so what I'm finding lately, I just recently tried to make an appointment for my in-laws. They were helping them out with their providers, and one of their providers got switched on them. Primary care doctor, and they wanted to get another primary care, and it took I think 2 or 3 months, and so then they had an urgent issue, and they had to decide, well, should I go to emergency room, should I go to urgent care, and we opted for an urgent care. Is that kind of the way things are? Is it replacing primary cares, or is it an adjunctive for weekends?
One of the things I tell my patients, we are not going to replace your primary care. In fact, we work as an adjunct, or we work in combination with your primary care. One of the other reasons that urgent cares has flourished because there's such a paucity of primary care physicians in the country. So having urgent care allows patients to be seen in a more readily expedient fashion.
Yeah.
So oftentimes primary care physicians cannot make enough time to see a patient of theirs, so they direct them to see us, and we work in conjunction with them. So when we see a patient that belongs to a specific provider, we will send our records back to them and keep them in the loop. Oftentimes, if I need additional information, I will call that primary care physician. Let's say they've done an EKG before, and I have an EKG and I want to compare them. I'd give them a call and see if they could fax it to me to make sure nothing's changed. changed and the patient doesn't have a serious or potentially dangerous ailment.
Yeah, so that's a good segue. So an EKG patient, what are some of the other typical patients that you see on a daily basis or a weekly basis in your practice?
It's funny you say. We see everything in the emergency, in the urgent care. In fact, sometimes a patient will come in and with life-threatening ailments, and we're still going to see them, but we will direct them into the proper facility, proper place. What we typically see and manage at the urgent cares are some viral or bacterial infections, sore throats, flu-like illnesses, urinary tract infections. We also do pregnancy tests. We do blood work, but we send our blood work out. So we contract with an agency. We'll send the blood work out, and in pretty rapid fashion, we'll get them back and let the patients know what we found. And again, we send that information to their primary care physicians too. So there's an array of things that we do, and we will see everybody. However, we will not manage everyone that comes through through the doors. We will facilitate appropriate dispositions for all the patients.
Yeah. So in terms of if they need lab exams, you can do that. How about X-rays, CTs, things like that?
Some urgent cares will do CTs and they'll do ultrasound. We don't. We have X-ray.
Okay, good.
We draw blood. We do point of care testing to get
EKG
immediate
like
results.
that.
EKGs, yeah.
Like for blood clot tests and things like that?
No, for DVTs and things like that. If we're concerned about that, we probably do a stat blood test and get it back in a decent amount of time. But for DVT type of studies, blood clot and the legs, we'll send or try to facilitate an ultrasound study to be done within, if it's early enough that day, if not early the next morning. If we're really concerned, we can start medications for that. Oftentimes, if it's real bad, we'd probably send them to the emergency department. But some urgent cares will have CTs. We feel that if we're going to provide that level of care to the patient, it detracts from being an urgent care and it streams more towards being an emergency department.
I see.
Yeah, so one of the things that we try to do, and we try to provide great care, but we want to facilitate so we can see the patients and not, for instance, in an emergency department, you would assume you'd have a higher level of care, people would be sicker.
Yeah.
So the length of time for waiting would be extended. At our place, we try to facilitate. If we cannot do these studies, if these patients warrant an MRI or CAT scan, we will send them to the ER. And although we're not mandated to do this, we will often call the ER in advance to let them know that this patient's coming in and these are our concerns. So it usually works out pretty well. And some of us still work in the emergency department.
Okay, so you do both things.
Exactly. So I'll call ahead and speak to one of the colleagues there, and I'd say, I got this person coming in with these type of ailments, these are my concerns. And oftentimes they'll call us back and let us know if our concerns were warranted, and usually they are.
Yeah, with all the experience. How about simple like cuts or lacerations,
Absolutely.
suturing things in their slivers and things like that?
Absolutely. We remove foreign bodies, laceration. Our urgent cares, we remove earwax. Some people have significant earwax. Laceration, broken bones will splint, reduce. We will basically repair almost any type of laceration. In fact, in the initial community, there was an urgent care which was proximal to us, but they didn't have emergency providers, so they would send us their complex lacerations, and we'd fix them and send them home.
And that's the difference, having emergency physicians there.
Exactly, it works pretty well.
Yeah. And then in terms of what are your, as a physician, we all have things that we prefer to do, that we like to do. What are the favorite things that kind of walk in on the daily basis that you would see every day, all day long? What are those types of things that you like, that you feel you can make a difference with?
Well, we see a lot of kids, and I personally love taking care of kids, making them smile, trying to get them through their hardships, trying to make it a little bit fun for them. But my favorite things would be, let's say, ear infections, sore throat with kids, and alleviating their consternations or their concerns. I enjoy doing lacerations. In this particular time of the year, call it this tick and rash time. So we just
if you're
got past
concerned
flu
with,
time.
Yeah, if you're concerned with
Lyme's
Lyme's
disease,
disease, yeah.
So we, in terms of Lyme's disease, everyone comes in and they're concerned about having Lyme's disease, which is warranted. However, we test for a complete tick panel. There are other bugs which will cause similar symptoms to Lyme. So we try to, I think we have 6 different tests that we do with our blood sampling to try to, but we affectionately call this the tick and rash season.
Different
That's right.
seasons
Different
that come around.
seasons, oh yeah. And this is tick and rash season. Next month is vacation rash and tick season. In September, the tick season goes down. You start ratcheting up for upper respiratory and pre-flu season.
Yeah.
We have our little terms and times.
Okay.
Yeah.
Do you do things such as like flu shots? And
Oh, yeah.
if someone
Oh,
comes
yeah.
in, they haven't
Yeah.
had their flu shot or certain
Absolutely.
titers.
We do flu shot. We even do meningitis shots for college kids. So some colleges were sending us all their students who are local. We will do tetanus, diphtheria, or pertussis tetanus. We sometimes we will arrange with special organizations to do additional inoculations or vaccinations too. So we work with the community. If there's a need, we try to help them.
So I'm sure everyone is, if they haven't been to urgent care, they're eventually going to be going to an urgent care. Basically, in our family, we use it. Let's say it's past 5 o'clock where the pediatrician isn't available, and we don't think it warrants an emergency room visit. We'll go to urgent care. What are some things that really shouldn't be seen in urgent care? Like things. Okay, you're thinking about going. This is the reason you should go and wait at the 8-hour wait at the emergency room. That's urgent care doesn't have that long wait. That's probably one of the attractions of it.
Absolutely. So we talked about the fact that we're ER trained folks. So anything that comes to the door, we don't send you out.
Okay.
If you're sick, our staff are trained enough to get you in there right away. So we'll see you, we'll have concerns, and they'll come and perhaps get me out of a room and explain to me the concerns of a specific patient. We'll assess them. Most of the times they're right. We'll assess them and get the person to the appropriate place. So things that I think should merit an ambulance call to the emergency department. For instance, acute non-traumatic chest pain, especially if you've had a history of it.
A history of a heart attack.
History of heart attack or cardiac disease, severe respiratory problems, acute.
So can't breathe, like emphysema.
Exactly.
Really
if you have a mild emphysema flare or asthma, we will see you and we'll treat you. We do albuterol and we have prednisone. We have steroids in there as well. But if you're really sick and you're really decompensating, you should call the EMS system. Other things like unilateral weakness, slurring of speech,
so
stroke-like
stroke
symptoms.
symptoms.
Those you should call an 911 to help facilitate getting you there, because most of these things are time sensitive too. So you want to save brain and heart. You want to get there to a facility that can manage it right away. There are many things that we will see, but will have concerns and want you to get additional tests. Like, for instance, abdominal pain. Abdominal pain can be a mild illness, like a UTI, or it could be catastrophic, like a ruptured appendix. We'll try to discern some of that, but to get a full workup with severe abdominal pain, we'll probably refer you to the emergency department.
We find that the typical Monday morning phone call is that someone goes in, they maybe are seen for an ingrown toenail, they might get an antibiotic, sometimes a little procedure. I don't find very many procedures being done, but they get an antibiotic and then they come in and we do that as a podiatrist. We fix the ingrown toenail or heel pain, and you'll see a lot of plantar fasciitis and things like that. I don't know if you have the cortisone to do the injection.
Some of my partners do. They'll inject. I don't inject because I'd rather someone who does it all the time will do that. For ingrown toenails, I will do those. If it's not really bad, I will treat you and send you to
a specialist.
Dr. Pelto, exactly. So we'll send you to the specialist to further manage and to follow, because as you know, most of these can be recurrent. So if they haven't established care with you, they'd see you. But we'd see everyone and try to disposition. We talked about having primary care physician. If someone does not have one, we will provide you information to try to establish care with a local primary care who's accepting patients.
So you can coordinate that.
We do.
Because that's a frustration for a lot of people.
We've gone out, prior to opening in these communities, we've gone out to the specialty care people, we've gone out to the physicians in the area, we've introduced ourselves, we told them what our mission statements are, what we want to do for the community.
Yeah.
And we told them, we will not take your patients away. We will be an adjunct. You can always refer to us and we'll get them back. I have a good friend who's a physician in the area. He was having surgery in March and he called me up, he said, last summer, and he called me up and said, I'm gonna be indisposed for this amount of time. We are going to refer a lot of our patients to you. And we said, absolutely. And if he can't see someone, he knows he can trust us, and we'll take good care of their patients, we'll send the information. If we're concerned, we'll call them. If I'm really concerned, I'll text them.
Yeah. It's great because one of the challenging things is, for example, for a urinary tract infection or something like that, you might give them an antibiotic, but they don't have a primary care, so they can't see the specialist because of their insurance, and it's just a big.
Yeah.
As an emergency physician, can you make a referral to a specialist,
Absolutely.
or do they still have to go
As
back
an urgent care person, yeah, absolutely.
So you don't have to go to the primary care, and then it seems like very inefficient.
We don't. In fact, at our other urgent care center, one of our providers often refer pediatric patients to Shriners because we, set a relationship with them. So they go there and they get great pediatric care. So we have providers in our area, as yourself, who've introduced themselves and agreed that if there's a patient that needs their services, we'll refer to them, and they've been great.
Neat.
They've been great.
And it's interesting, in every industry, things are changing in the future. And as insurance changes, healthcare changes, where do you see the future of urgent care? One thing that just kind of popped into my mind, do you think you'd be maybe over the internet kind of treating patients at your urgent care via webcam type of thing? Or what do you think the future of your...
It's funny, I'm a big gadget freak, so if a gadget comes out, I have to get it. And I have some hesitancy in terms of care over the phone, and if I can't really touch the patient. However, it's coming. We know that it's coming. What do I see in terms of the success of the urgent care? As long as the medical climate continues and the majority of citizens in our country have insurance, I think we'll flourish. One of the things we've done is we've debulked a lot of the emergency departments. So the backlogs of people that are waiting in the emergency, they will segue to us.
Will they refer to you sometimes, or
no, they can't do that.
They can't do that.
But patients will come to us instead of going there for minor. A lot of things we see in the emergency department are minor and could be seen at an urgent care. And if it decreases your time, it's better to go there. Emergency department should have emergencies,
life-threatening
or serious, or potential life-threatening. Sometimes the public cannot discern if this is a true emergency, and that's fine also. But I think we're here to stay, provided that the political climate doesn't change, how things are structured.
I guess that's the question. Is most of it insurance-based? Is it cash pay-based?
It's both. It's both. In fact, the insurance companies favor us in many instances because in terms of a cost
overhead
analysis, it's cheaper to be seen at our urgent care. So we've contracted with many insurance companies. Our fees are less than they would be if you'd gone to the emergency
because they have more
department.
Resources there,
Exactly.
Bigger buildings and everything.
Exactly, and bigger charges. And I think patients favor the lower costs of the copay to come and see us.
What is your copay versus like an emergency room copay?
They're usually a lot less.
Like $50, something like that?
It depends. It varies with your insurance, but $20 to sometimes $200.
Okay.
But it's usually less
than an
emergency department. But I don't think we're going away anytime soon. I think in the past when urgent cares opened, the climate didn't favor urgent care. So a lot of them failed because there was really no catch net. people didn't have insurance, and unfortunately, they had the ability to go to the ER without being burdened with a bill right away. But in terms of financial stability, patients could not afford ER visits. So the care was poor, and when they got to the emergency department, they were very sick. And since the explosion of urgent care centers, it's been documented or studied that American healthcare has gotten better.
Really?
Yeah, which is really important.
Now, as we conclude here, is there any need for let's say they come in today, and then you do a few tests. Do you see them back in 3 or 4 days or a week?
Yeah,
that type of follow-up?
Certain things. First, like my elderly, as an example, my elderly patients who have a laceration, and I want a wound check. We will see them for the suture removal
in 2 weeks or something like that.
in 2 weeks.
Yeah.
However, oftentimes I have them come back for a scheduled recheck because I want to make sure it's not being infected and it's being well cared for. A lot of them live alone, so those we make special arrangements for them to come back. So we will see them back if their primary care can't see them. If they can be seen by the primary care, we'd rather that as well.
How about, for example, certain things that you would set up, like a visiting nurse visit, things like that? Is that done through you, or you typically don't do that?
We don't do that. We let the primary care, again, we don't want to take the place of primary care. What we say is that we're here for your episodic care.
Okay.
You have a mild ailment or something that we can manage right away, we'll do it. Comprehensive care should come from your primary care physician, the person who manages your blood sugar, who does your A1C, who takes care of your hypertension. That should be done with a primary care physician who can give you the allotted amount of time for that particular ailment or complication or complicated medical histories, and facilitate appropriate care and specialty care for the patient.
Perfect, perfect. Well, thank you, Dr. Rock.
Thank you for having me.